Good afternoon. I'm Dr. Bancha Chujit from Thammasat University, Thailand. Thank you, the MAS committee, for inviting me again. Thanks my Penang fellow, Dr. Lim, for preparing the information. Today, I'm talking about the meniscus root tear, how I handle it. I'm the big fan of MAS meeting. I have never missed your meeting except last year because of COVID. It's a great privilege to be part of this meniscus symposium. This video shows the anatomy of the medial and lateral meniscus. The lateral is more mobile comparing to the medial side. This picture shows the anatomy of the meniscus root. Easy to remember: 6, 8, 10, 12. Increase every 2 millimeters. The posterior root of medial meniscus is close to PCL, and the anterior horn of the lateral meniscus is close to the ACL. The meniscus root function is to convert axial tibiofemoral load to hoof stresses, and the 50 to 70% of the knee joint load was absorbed by meniscus. Biomechanical study by Robert 2008 found that tear of the posterior root of medial meniscus is comparable to total meniscectomy. In terms of lateral compartment, similar trends at medial side: 50% increase in peak contact pressure after lateral root detachment, and after the repair, the native contact pressure come back. How about the natural history of meniscus root injury? Once the root is torn, the meniscus will detach from the tibial plateau. This will alter the knee kinematics. Then, meniscus will extrude more and more, finally diminishing the hoof stress effect, resulting in rapid progression of osteoarthritis of the knee. Many articles mention about the natural history of the meniscus root tear. One article found that 1/3 of the patients need joint replacement 3 years after the initial diagnosis. JBJS 2009 mentioned about the high correlation of osteonecrosis and root tear. They conclude that 80% of osteonecrosis associated with medial meniscus root tear. This is one of my Japanese patients. She had root tear and was treated conservatively. 2 years after that, she has osteonecrosis and needs joint replacement afterward. In this literature conclude that the incidence of medial meniscus root is very high, nearly 80% in primary total knee replacement. These are the differences between the medial and lateral meniscus root tear. The medial meniscus root tear is common in middle age, can be acute or chronic repetitive injury, can be from minor injury like twisting, squatting. The tear configuration is always radial, close to the root attachment. For the lateral meniscus root, is found in younger age, acute traumatic injury, and always combined with ACL injury. This cadaveric study from arthroscopy 2021, after performing the lateral meniscus root detachment, it significantly increased the rotational and translational laxity at 30 degrees of knee flexion. These are the risk factors for posterior meniscus root tear: Wallace malalignment, increased BMI, female with high KL grading. Clinical presentation: the patient always complains posterior knee pain, especially when walking or deep bending. Examinations reveal joint line tenderness, McMurray test positive, and severe pivot shift test positive in lateral meniscus root tear. MRI characteristics of meniscus root tear includes meniscus extrusion from edge of tibial plateau, ghost side positive in sagittal view, cleft side positive in coronal view, and bone marrow edema of the tibial plateau. The lateral meniscus root is often misdiagnosed, 33% missed on MRI. The normal lateral meniscus root should be like Y shape. One limb is root, one limb is Rissberg ligament, like the first picture. Sometimes we see no gap of the meniscus. It's just floating like the third picture because the Rissberg ligament is still attached. Dr. Rablatt classified the meniscus root tear into 5 types. The most common is type 2, 68%. The complete radial tear within 9 millimeters from the attachment. How about the root repair outcome? The recent meta-analysis from American Journal of Sport Medicine 2021 of 994 meniscus root repair patients The clinical outcomes were improved in all studies. Anyway, 50% had X-ray progression at least 1 grade of KL at 4 years follow-up. This paper, 2019, compared the outcomes after medial and lateral meniscus root repair in 141 root tear. They found that the lateral meniscus root tear had less extrusion, and the result of the repair is better comparing to the medial meniscus root. Repair versus meniscectomy. The recent meta-analysis comparing long-term X-ray outcome and conversion rate to joint replacement. Conclusion is that the root repair group had lower rate of OA progression and conversion to joint replacement. How about the management? We need to consider 3 factors: alignment, cartilage, and ligament. The treatment options include conservative treatment and operative treatment as shown. Operative treatment includes meniscus root repair or recon, meniscus extrusion reduction, correct the alignment, or joint replacement. The goal of root repair is to prevent the arthritic change. It's indicated for acute or chronic tear without osteoarthritis. KL should be less than 2. The good candidates for meniscus root repair are acute injury, no joint space narrowing, and extrusion less than 3 mm. Don't do root repair if there's subchondral bone collapse, malalignment more than 5 degrees, and BMI more than 30. These are the bad candidates for root repair: chronic injury, joint space narrowing, large tear size, and extrusion more than 3 mm. This systematic review in 2019 concluded that 2 factors that make the outcome worse. Number 1, the pre-existing cartilage lesion, outer bridge more than 3. Number 2, malalignment more than 5 degrees. What is the proper timing of meniscus repair? This article in American Journal of Sport Medicine last year suggests that early surgical repair of meniscus root within 13 days after the injury can prevent the progression of medial meniscus extrusion. Now let's talk about the surgery. I will discuss about the different techniques of surgery, suture constructs, and do we need extrusion reduction. I prefer this position. I break the table, hang the leg down, and I can move around the knee. Let's talk about the first technique, the transtibial pull-out repair. This is our technique published in 2016, medial meniscus pull-out repair with the use of tibial tunnel suturing technique. We repair the root in Mason Allen configuration and secure with cortical button. In 2016, George proposed the double tunnel pull-out technique. He claimed that this technique may increase the contact surface at the root and better contact healing. This is my patient with double tunnel pull-out technique. I did the suture bridge configuration like rotator cuff repair to increase the surface contact healing. In systematic review, complete healing on MRI varied from 60 to 90%. Extrusion was reduced only half. Most patients improved functional outcome after the surgery. 80% has no progression of osteoarthritis in short-term follow-up. Professor Somsak from Chulalongkorn and the team proposed the very smart soft anchor fixation using flexible drill bit, which can press the soft anchor more vertical. This is my preferred technique of meniscus root repair with soft anchor. The benefit of this technique is that no need to do the posteromedial portal, no tunnel convergence, and no bungee effect. After MCL release, I create the mid-medial portal. Use the ME device to create the tibial tunnel. The assistant in the back table preparing the soft anchor by passing a suture tape to secure it. Then I throw the PDS suture from tibia into the joint as a shuttle for the soft anchor to drag it in to the tibia. After that, repairing the root in Mason Allen fashion. The medial joint space always very tight during the surgery. This is a big problem during the surgery. I propose the technique to open the medial compartment we call magic point release. The landmark is 1.2 cm above the joint line, connecting to adductor tubercle. Transtibial pull-out versus anchor suture. Which one is better? Dr. Kim compared 2 techniques, pull-out repair and suture anchor repair and found that there's higher rate of incomplete healing in the pull-out group. Professor Imhoff and the team from Munich compared suture anchor and pull-out repair. They found that suture anchor technique provides superior biomechanical properties. How about the suture construct? Biomechanical testing proved that the double locking loop is the strongest, and the same result found in this article. Another interesting stitch is a simple cinch stitch, single pass, high load to failure, low cyclic displacement, and decreased cut-through. The meniscus extrusion, do we need to reduce it or not? This article proposed that the non-reduced meniscus extrusion decreased shock absorption and increased progression to osteoarthritis, so only root repair may not enough. Dr. Jin Gu Kim found that the decreased meniscus extrusion group have better leach home and IKDC score and less KL arthritic progression. I propose the surgical technique for arthroscopic direct meniscus extrusion reduction. I use the mid-medial portal to place a soft anchor at the edge of the tibia, then reduce the meniscus to the anchor in horizontal mattress fashion. When should we do HTO in root tear? Some root tear patients can be late and had malalignment, so HTO combined with root repair is the way to manage this situation. I prefer one-leg standing view because many times two-leg standing view look very normal. This technique is very useful to detect the actual joint space narrowing and axis deviation. The indication for HTO plus root repair includes acute onset of root tear less than 6 months, medial extrusion less than 5 mm, and the KL less than 2. 50 years old lady just progressive right knee pain for 6 months after squatting. MRI showed the meniscus extrusion with subchondral marrow edema, the Krebs side positive and the goat side positive. First, I did arthroscopic meniscus root repair with Mason-Allen fashions, followed by HTO. How to save my suture repair from HTO saw blade and chisel. I use the endo button drill bit to protect my suture all the time during the HTO. 6 weeks after the surgery, the patient doing very well. Dr. Kim proposed that it's not necessary to repair the meniscus root during HTO because the outcome is the same. Another study also supports this. Root repair may not need during HTO. This systematic review in 2021 concluded that HTO plus root repair had higher rate of complete meniscus healing, so I myself still prefer to repair the root plus HTO. This is the last issue, meniscus root reconstruction with gracilis tendon. It was proposed by Dr. Jin Gu Kim in 2017. The benefit of using gracilis instead of suture is that it's a soft tissue bridge from meniscus into the metaphysis bone, so it can close the bigger meniscus defect with good healing potential. 60 years old, medial meniscus root tear. I did the root reconstruction for him. Nice root reconstruction healing into the bone 2 years after the surgery. Rehabilitation for the root tear need to be very slow. It's easily torn if putting the weight on too early. 6 weeks, no weight bearing. 6 to 12 weeks, progressive weight bearing. No squatting, no jumping for 9 months. Take-home message. Root repair is indicated in all acute tears. In chronic tears, we assess the severity of arthritic change. In mild and moderate arthritis, we do repair or recon depending on the extent of extrusion and gap, with or without HTO. In severe arthritis, we recommend HTO or joint replacement. Thank you for your attention.